All right, perfect. So what we're going to show here is just a little bit of a demo for recoveriX. We're going to first start off with upper extremity in this case, and therefore you already kind of see the posture that our, in this case, subject is sitting in front of the computer screen. So we have both the left and the right hand and arm comfortably rested on the table in this case. We also already have the electrodes prepared. So these electrodes we will later on stick to the forearm muscle. And of course, we still are missing the EEG, right? And also we have the recoveriX system itself, which we will still have to like configure everything, which is really not much to configure, so it's very user-friendly. So first, here on the computer screen, I will not just select Evgeny. So I created a recoveriX patient, here you can see it. And the first course of action is to just select Evgeny. And now you can see this user interface that already Christoph mentioned. And for that one, we will just select right wrist and left wrist therapy. As soon as I click on that, we see that currently no experiment has been run yet because Evgeny is a brand new patient or subject. So the first thing that we will do is we're going to open the avatar, for example. So this is this 3D avatar that will be popping up on Evgeny's screen, showing again the same kind of POV, the same view that also Evgeny has of himself right now, meaning both left and right hand comfortably in front of him. And now we're going to go to the FES, right? So these FES are the functional electric stimulation electrodes, and we have them from the left hand and for the right hand. So this is the first thing that we will apply in this case, right? So before applying them, it's obviously always important to connect them first. So we have a red one and a black one. And these go, of course, in the FES electrodes. Make sure they're nicely in there. Now we have it for the left. Then we have these medical swabs. So these are just some alcohol pads for degreasing the skin, decreasing the impedance as well. And to get basically the skin nice and dry, even though initially they will be wet still. So we're going to do this for the forearm. So this will drastically reduce the impedance of between the skin and the electrode. And you of course want to have that in order to get a good electrical stimulation for a subject. So now I did it for the left hand. Next up is the right hand. We're going to use a brand new one. Also for this one. It's good to first do the left hand, then followed by the right hand, because you might be able to see that after I use the swab, it's still a little bit wet because of, well, the liquid and the alcohol. Now we're going to connect the right FES electrodes as well. And then we can go back to the left one. So these are brand new FES electrodes. And already themselves, they stick very, very well to the skin. But just in case, in order to make the impedance a little bit better, I'm going to just apply a little bit of gel here. Not too much at all. And gently stroke over it with my small little finger. Spread them out nicely. And then the most important thing is to find the correct location in the forearm. So for the arm, it's not that tricky, but again, you just want to ask the patient or the subject to move the hand. Okay. And you can see the muscles working, and I can also feel them. Go it down again, up. Exactly. So once we have identified kind of where the muscles are that are working, which according to anatomy, it shouldn't be that difficult, but especially for stroke patients or MS patients, it can be fairly difficult. We can then place the electrodes. So the first one I'm going to place roughly here. And the other one I'll place roughly there. Okay. Make sure that they're nice and close up. And now I can already start stimulating Evgeny. Of course, you want to warn the subject that, okay, I'm putting on the stimulation now. And I'm going to gradually increase the curve. So now you should be maybe feeling something already. Then I'm going to pause it again. So you don't want to keep stimulating and stimulating. I'm going to click on start again. And now slowly his hand should be moving up. You can already see the little index finger moving up. I'm going to pause it and the index finger is going down. Right? Start again. Index finger is going up. And now I'm going to gradually increase it until we have the wrist dorsiflexion. And there it is, perfect. Going to click on start again. Ask the subject, is this okay? Perfect. Okay, beautiful. Then click on pause again. And now we have the left hand completely set up. Everything's working perfectly, which leads us to the right hand, of course, right? So, same exact play on the right hand as well. Also here, could you please move the hand? Okay, perfect. So you can just palpate the skin and feel the muscle. Thank you. I'm going to remove or prepare the FES electrodes again. Again, just put a little bit of gel on there. So the gel is not necessary, especially if the subject doesn't have like too much fluid or stuff under the skin or in the arms, whatever. But it does make it easier to then remove the pads again, especially if somebody has hair on the forearms, for example. Otherwise, they get a free shaving, which not everybody likes, right? So now that the right side is prepared as well, I can now start stimulating the right side. So we switch in the software to the right FES. And I'm going to click on start stimulation. And I'm going to again slowly increase it. We're now at roughly the sensation point again, where Evgeny kind of feels it. Going to increase. Going to pause it real quick. Going to start it again. And now slowly, there's again the activation going, right? So in this case, the electrodes are probably, especially this one, a little bit too far in, because there is a little bit of like a bicep activation. Mm-hmm. This is perfectly normal. And that's why we can ask the subject, okay, how does it feel? Is it okay like that? Or should we put the electrode somewhere else? And then we reposition them. And we can just stimulate again, right? So I'm going to click on start again. I'm going to immediately reduce the current a little bit. Going to pause it again. Click on start again. It's a little bit too little movement. Increase again. And now it's there. Perfect. That's all we want. And now that the FES is set up, we can go to the EG finally, right? So now I can already click on start here. And I'm going to show you how to prepare good EG data, right? So for now, obviously, here you can see it in the bubble scope and also in the traces themselves. We don't have any EG at all. Like these are just either flat lines or floating channels. Why is that? Well, if you look at Evgeny's head and at the cap here, it's not connected to anything, right? So this is what we're now going to be caring about. Me just moving the cap about also leads to floating channels. Again, this is not EG data. We need to actually apply the cap to Evgeny's head. This you do just gently putting it over his head and making sure that everything is nicely lined up. And now I can close the chin strap. Make sure the chin strap is nice and tight in order for the cap not to move during the therapy, right? So we now have a bunch of channels, which you can see. And we also have this ear clip. So the channels are mostly covering, as Christoph, I'm sure already mentioned, the sensomotor cortex. And that's what we're interested in, right? Trying to decode movements. And we have this little ear clip. The ear clip is used as reference. So now I can already start gelling channels, but I'll show you why this ear clip is especially important, because that is the reference channel. So if I grab my syringe, and maybe we can get a close-up shot. So I usually hold the channel a little bit, or I can show you perfectly for channel 3. It's a good angle. I usually hold the channel a little bit and press it onto the skull. The reason is if I just put in the gel here and I put in way too much, it might spread and then create either shortcuts or doesn't give me a good signal. So I press down just a little bit, then I put in the syringe. Try to get the hair aside a little bit by scraping. And now I'm filling in the gel until it comes back at me. So this is what I did for channel 3 now. You can do the same exact thing for channel 2. You can press down a little bit, put the syringe in, get the hair, the laces aside a little bit by scraping. And this does not hurt the subject. Putting in the gel now until the gel is coming back at me. Right. Now we have done 2 channels. Third channel, I'm going to do just the exact same way. Now the first 3 channels in theory are gelled. If you look at our signal here, it still looks extremely bad, right? And this is exactly what I meant with the reference, this little ear clip, as well as the ground electrode are extremely important because these need to have good contact. Otherwise, you're not measuring anything at any point. And this is not just the case for recoveriX, it's the case for every ET system. The ear clip, I put some gel on the ear clip, and now I can put it to his earlobe. And now I can also gel the ground electrode. So these 2 channels are usually the first 2 that you want to gel. I just didn't do it for like showing purposes, basically. And now everything should be getting a little bit better in terms of EG signal quality. Next up, we're going to be gelling all the other channels. So channel 4 is up next. And in theory, I could do these like quite quickly. But again, this is for you to learn. And for that, I'm going to take my time to explain everything to you. So usually you can set up the EG, especially with just these 16 channels. And I want to say 3 minutes, and then everything is already good. Except if somebody has like an afro. If they have an afro or tons of hair, you might need 5 minutes, but that's really it. So now we have channel 1 to 10 gelled. Going to be gelling the other channels as well now. Gelling channel 11. So now went from 11 to 15. And now just PZ, which is channel 16, is missing. So now we can kind of wait and see what the channels look like. And we can check for channel 3, for example, which is now also coming in. And if everybody's holding still, the signal is actually perfect, right? So now everything is settling. EG quality is improving. And we're basically ready to go with the therapy. We can, for example, ask now if he needs to blink with his eyes a bunch. And this leads to these artifacts. So these are like slow frequency artifacts. We can also ask him to close his eyes, which will lead to some alpha waves. And for example, the classic clench your teeth. which lead to these massive high frequency artifacts, right? Obviously, that's not brain signal. This is just from his muscles that connect to his jaw, which attach to the scalp as well. Right? Just gonna add a little bit more for PZ. And then we're actually good to go, starting the therapy. So for this, Uzi can show the avatar screen. So you've already kind of seen what it looks like. That is, there's going to be left and right side arrows popping up. Then there will also be sound. The sound you might not be able to hear because I'm using a headset, which will mostly pick up my voice in this case. But as soon as I now click on start, there's going to be randomly left and right side arrows popping up, indicating to the subject to either imagine left hand or right hand movement. Right? And I can click on start if Evgeny is ready.
Yes.
Evgeny is ready, and now we can click on start, and on we go with the therapy. Evgeny will also be receiving the FES. So he's not actively moving his hand. Okay. FES, so the left and right hand stimulation, the functional electrical stimulation, that's the one that is actually moving his hand. And as you can see, the left and right side commands are coming in randomly, meaning the subject cannot prepare for the next stimulation incoming. So just because now the left side was stimulated doesn't necessarily mean that next time it's going to be the right side. You'll see now it was left twice in a row and right twice in a row. So we're going to let Evgeny do a bunch of trials here. In the meantime, for example, I, on my left-hand monitor, can either see what is coming up next, whether the next trial is left or right side coming up. For example, you can see this here. I can also monitor his EEG, which looks quite good. And that's basically it already for the hand therapy in this case. So of course, you don't want to disturb the subject. So let's say if I was a therapist, I don't want to talk next to the subject. That's also why we don't have a patient here sitting, because I really want to make sure that the patient has the biggest chance possible to concentrate, to focus, and to make the most out of the therapy. Because it is quite difficult to concentrate while somebody is just blabbering on in your ear, like I'm right now doing with Evgeny. One good thing, for example, about recoveriX is I can pause at any point. So I can do this, for example, now. And now everything is paused. This could, for example, be like right now, oh, I see that, for example, the C2 electrode is a little bit worse than the other electrodes. And I want to really make sure that it also has a good signal. Or, for example, I can change the FES. For example, the subject might tell me, oh, it's actually a little bit too much current or stimulation, or it's a little bit too little current or stimulation. And you can always fix that. And that is important because the subject should be comfortable. The EEG signals should also be good. So I can now go and fix the C2 electrode, for example. By again, scraping the hair aside just a little bit. Now again, putting the gel in. And now also C2 is okay. I can again ask the subject if they're ready and wait for the EEG to fully settle. And I can click on start again. And the subject is back to working. So I'll now let Evgeny do a bunch of trials. And we will then switch to the foot therapy afterwards. So during the therapy, I'm sure Crystal mentioned that as well, you will be doing 80 repetitions for both left and right hand. And this is the first run or the first block of therapy. Usually there's these 3 blocks that we're doing. And the first one is always used for the calibration of the whole BCI and algorithm. what will soon pop up, for example, on my laptop screen as well, are going to be the ERD and ERS patterns. Also, again, pretty sure that Christoph has told you about them already. These will be in the bottom here, so that you see these these 4 squares or rectangles on my screen. I'm going to point to them with a syringe. Here's the C3 electrode, and here the C4 electrode. The C3 electrode here is, for example, over the left hemisphere, responsible for the right hand movement. The C4 electrode is on the right hemisphere, mostly overlaying the primary motor cortex of the left hand area. Now you see these nice little colors, right? They will get more and more clear the more trials, for example, or the more repetitions that Evgeny is doing. Basically, red means event-related desynchronization. So this is, you can kind of interpret it as activation of the cortical areas or cortical excitability, meaning that currently these areas are working, which of course is exactly what you expect, because Evgeny is, after all, doing motor imagery.
Sebastian Chandra is asking, how many FES electrodes do you need, and are you stimulating the muscles or the nerves, or what are you doing?
So we use for recoveriX 2 FES electrodes. You can see them nicely here. 2 for the left hand and 2 for the right hand. Or basically, we're using 1 pair of FES electrodes, of course. And we're stimulating both the muscle and the nerve. So it's not necessarily direct nerve stimulation, but stimulating both. Okay? So you try to apply these according to the motor point that is going into and innervating the muscle. And that's where we put the electrodes. The electrode positioning, while standardized, is subject dependent. Okay? And this is also why I asked Evgeny, for example, to really move his hand. So you can see, for example, maybe for my hand, if I'm doing the movement, there's also muscles active, and like my hand is moving and my forearm is moving. While, of course, we all have the same muscles that are innervating roughly at the same point, especially in pathologies like stroke, when there's muscle atrophy and similar things, then it can get a little bit tricky where to put the electrodes. So you always want to make sure and ask the subject, okay, could you move it? And if not, for example, you can also passively move the hand. And if you passively move the hand, for example, there's also going to be muscle contraction or change in position of the muscles. So now we are, for example, at a halftime break. Just going to click on skip and resume with the therapy. So yeah, of course, in theory, one can put a lot more FES electrodes, but that makes the whole setup just a lot more tedious. It makes it more difficult as well. So you want it to actually be as straightforward as possible. So really minimize the amount of work that the therapist needs to do and contrast that with the amount of benefit that the patient can get. And that's what we, in this case, chose 2 electrodes.
Another question is from Lisa. She wants to know if there's a difference in classification accuracy depending on IQ.
I wouldn't say so, just because, first of all, it wouldn't make too much sense. Okay. Also, I don't want to insult any of my colleagues. So there's a bunch of people in our company, for example, that are really trying their best, but do not have a good accuracy. And they're really, really clever. They're really, really smart. But I just don't see the relationship in this case. So it's definitely a lot of practice. Some of it is, for example, related to the amount of the sensory motor rhythm that you have. So this has already been shown that if you, for example, have strong mu and beta activity that respond very, very well to motor imagery or to motor attempts or motor actions, then you will probably perform very well at motor imagery and thus have a good accuracy. So there are prediction factors which influence that, which are, as far as we know for now, completely decoupled from IQ as well.
Arthur wants to know if it would make any sense to couple recoveriX with neuronal stimulation, like electrical brain stimulation, magnetic brain stimulation, or even infrared light stimulation.
Mm-hmm. It would make sense, or it is at least something that would be very interesting. Let's put it that way. It is just much, much more difficult to actually do that study, right? So I, for example, always give the example to both patients and to their relatives of, okay, we're trying to decode here movements based on what we record on the scalp. So as you can see, these electrodes are just on the head, but we're not there for measuring like the same kind of really like colorful signals that we can measure on the cortex itself, right? So as you already saw in the spring school, you can do really amazing things once you're measuring on the cortex. Once you have these implants, you can decode individual fingers and everything. You're just not able to get that same kind of signal from the scalp. So it's much more difficult, right? So it would be, for example, interesting in, okay, how does the amount of therapy effect change if you have, for example, kind of implanted electrodes, or if you directly then stimulate the brain areas surrounding, for example, the lesion, and you try to get these good again. But again, this is, in a way, it's completely impossible because it's like the amount of benefit risk analysis, it just doesn't pan out for you, okay? You can't just implant or stimulate directly the brain just because you think that it might be more beneficial to the patient. But for example, something like TMS coupled with recoveriX could work very well. So
Sebastian, how should we do it? We have a couple of more questions. Do you want to continue with this session, or do you want to assemble first the gate treatment and then we continue with questions?
I'd go for that, yeah. So I'm going to now pause recoveriX, and we're going to switch to the lower extremity treatment, just so you can also see how this one looks like in real life. Once we have assembled that, I'll continue with all the questions. So I'm going to exit the current session, which is usually not what you do, of course. We're going to back to the overview, and now we're going to go next up to the left hand and a right foot therapy, okay? So for this, we need to reposition a subject or a patient as well. So we're going to disconnect the electrodes for the right hand, and I'm also going to remove them. And now I'm going to ask my subject to stand up, and I'm going to reposition the chair. You can sit down again, perfect. So there's some things that are important here. So for one, subject can of course always leave on their shoes if they want to, otherwise they can take them off. It really does not matter. And we really want to make sure that the foot is nice and comfortable. So there shouldn't be any stress, for example, on the back of the foot because the cushion or something isn't ideal. So I'm always asking, is it okay for you? Should I put it further back, further forward? We can also adjust the height here as well. So everything is possible in theory. And the subject shouldn't be too far from the table, right? Because the left hand in this case is resting on the table. And if I'm now putting the chair back here and the subject has to do kind of like this movement just to get the hand on the table, it's not going to be comfortable for a long time and definitely not for a whole therapy. So for the foot, we have a little bit bigger electrodes in this case. Again, I'm going to plug them in. We again have a swap for his right leg. And I'm going to just gently use it. will again prepare the electrodes now. Again, just putting a little bit of gel on the electrodes themselves. Again, stroking it with my little finger, like spreading it out. And now it's again time to ask the subject if the subject or patient is able to really move and perform a dorsiflexion with the foot. So you can see it really, really nicely for Evgeny. I hope it shows on the camera that there is one muscle that is clearly contracting in this case. Right. And this depends, of course, on the subject, how lean they are, for example, and how big the muscles are. Otherwise, you can, again, for example, also move the subject's foot. You just don't do anything and you move it. And you will also see that there is the muscle activation, or is at least a contraction, a shortening of the muscle. So I'm going to now apply the FES electrodes. And the cables are very long, which makes it nice also to handle the foot and not just the hand, which is much closer to the FES. And I'm going to apply the first electrode roughly here. And the second electrode just a little bit below here. In this case, the cables are going out this way. No strain on the cable or anything. And we can now again go to the stimulation side. I will be selecting the right ankle and left wrist because we're stimulating the left arm, and the right ankle. We're going to be using the classic avatar in this case. And I'm going to be setting up the FES. So of course, one thing is still clearly missing, as you can see. The subject will not be looking to the left side the whole time, to the computer screen. So also the computer screen needs to be adjusted in position. Something like that. Just so that the subject is nicely able or comfortably able to look at the computer screen. We could even, it depends on what your setup is. We can also put it literally in front of him, for example, in pole position. Really have a good view, but for demonstration purposes, this will do just nicely. Now, usually I'm starting then with the hand again. So I'm starting the left stimulator, increasing the current. At this point, I already kind of know how much he needs. Usually would again ask always the subject if this is okay, if they need more, if it tingles, if it hurts, or whatever it might be. Now we're going to go to the right foot. The foot or lower extremity always needs a little bit more current than the hand. So for me, for example, it's nearly a factor of 2, which is just because it's a different muscle, right? So now we have a little bit of movement already. Maybe you can see, I'm going to pause it again, start it again. Just a little tiny bit. Going to increase the current more. And now the foot is lifting up already. You want to go more, or is it okay? Okay. So subject is saying, it's okay, I can add a little bit more current. And that's it. Too much, or is it okay? It's okay. Nice. So again, I click on start. The system is showing me the EEG traces. We're going to wait until everything is nicely settled. You can ask the subject again to relax, close the eyes, for example. And now, are you ready? Yes. And we can click on Start Therapy again. So again, also in this case, the subject sees these arrows pointing to the left and right side. There's also a ball which shows up at the respective side so that the subject can kind of imagine, okay, I want to touch that ball with my thoughts. Or like I want to imagine the movement that I'm touching that ball. And again, subject is only imagining these movements. This, for example, becomes extremely obvious if somebody's trying to move it. If, for example, the FES, meaning the functional electrical stimulation, isn't even active yet, and already the hand is going up, right? It's then clearly somebody's actually trying to move their hand instead of letting the FES do the work. Right. And while Evgeny is working, I'm here to answer more questions. So I'm free again.
Thank you very much. Salini is asking, can you explain the Ashworth scale?
Okay, so the modified Ashworth scale is basically a scale for spasticity. It goes from 0 to 4 points, and it kind of tries to quantify, okay, how big is the spasticity, with 0 points being no spasticity, and then 4 points being extreme spasticity, so extreme rigidity. What is spasticity? Spasticity is basically, simply put, an increased muscle tone, right? So that becomes quite obvious if, for example, Lucy, who's usually doing these assessments, is trying to move the patient's hand passively, okay? So you instruct the patient, okay, don't do anything with your hand, just leave it completely flaccid or like completely relaxed. And then Lucy is, for example, moving their hand. And what you typically want to do is you want to count to, like, let's say 1001. And during this time, you want to go from, let's say, full relaxation from here to full extension up here. So you want to count 1001. So why are you counting this weird little way? And that is because you always want to do it the same speed, okay? So if I'm, for example, doing it like that, that's way quicker than it should be. So it's again 1001. And when I'm finished with this 1001, I really want to be up here, right? And then you try and quantify, or there is exact criteria actually, of, okay, when is it 1 point, when is it 1.5 points, when there's 2 points, 3 points, and 4 points, right? So for example, if I can move it nearly the whole way, but just at the end, there's a little bit of spasticity, then it would be, for example, a 1 in comparison. If I cannot move it at all, meaning this hand or arm then usually looks something like this. So usually there's also finger flexion going on because spasticity tends to be a whole flexor issue. So everything is kind of flexed, something like this, for example. But for now, I'm going to show it like that. And then Woozy is trying to move it, or the therapist is trying to move it, but it's not budging an inch. Like it's not moving at all. And this would be, for example, 4 points. And you can do this not only for the wrist, where I showed it to you. I can also do it for the hand or for the fingers, where it kind of looks like this. I'm trying to move it up and down again. Or I can do the same thing for the foot, where I move this. And for the knee, the exact same way, right? So this would be the modified Ashworth scale or the spasticity scale.
Very nice explanation, but now we need it a little bit faster because we have so many questions and we have only 5 minutes left. Gaurav wants to know, how much longer do patients benefit from recoveriX?
For the upper extremity, we did a very, very long-term follow-up. So this is 6 months after the therapy. and we didn't see any decrease. Okay, so no statistical difference, no deterioration or anything.
Arthur wants to know, can you use recoveriX for something besides stroke or even for healthy people?
There's people who will be investigating it for healthy people. What I can definitely tell you is motor imagery is extremely beneficial. So you can see it, for example, for professional skiers, professional climbers. They're really like going through the route and trying to imagine what it feels like to be on that route. So you can not only use it for stroke, you can not only use it for spinal cord injury maybe as well, or MS. There's also benefits for motor imagery in athlete sports. Okay, so it's not just lay people, it's not just patients, it's the really best people in their field are using motor imagery.
Soinik wants to know, can you apply FES on healthy muscles?
Yes, absolutely. Yeah. So for example, if Guinea is completely healthy, we're applying FES right now to him.
Should patients actually be instructed only to imagine the movement and not to do it?
Yes, this is the approach that we're going for. One reason is it's more cognitively engaging. It's much more difficult, actually, than just performing the movement, especially if there is still residual movement, for example. So, for example, for me and you, it would be easy to just move it. But it is much more difficult, actually, to really imagine moving the hand.
Jacqueline wants to know, are you doing the calibration in every session, and how would the EEG variation from one session to another one look like?
I'm sure for a healthy subject, it is okay to go from one session to the next without retraining. For patients, it's really important to retrain, just for them to really get into the flow again, really get used to everything. So it is a little bit more variance and variability in patients in comparison to healthy people. Yeah, but we're retraining every session.
Soinik wants to know a little bit more about the stimulation parameters.
For the upper extremity, for example, so for stimulating the hand, we are going for example, 50 hertz, and we are going for 300 microseconds pulse width, and then the intensity, meaning the current, that one is really variable. It's dependent on the patient, on that day, and everything else. For lower extremity would be 400 microseconds. There is, to the best of my knowledge, no clear-cut standard. There haven't been many studies, if any studies, which really investigate, okay, what is the optimal parameter?
James wants to know, what is actually the BCI system doing? He understands the motor stimulation and the visual feedback, but what is the BCI doing?
The BCI is doing the following during the really rehab training runs. The BCI records the EG activity, right? And we're using it to train an algorithm, and the algorithm is then deciding if the patient is properly participating. And if the patient is properly participating, meaning the BCI system is able to detect these left and right movements, only then the patient is getting the stimulation. And this is a basic reward circuitry. So meaning if you do something, you get a reward. If you do it properly, you get that reward. And through that, the brain is able to learn again.
Jacqueline wants to know, how do you calculate the classify accuracy? Because the movement isn't observable. So where does the number come from?
So the classify accuracy is typically, if you want to be really get into the weeds, it's temporal cross-validation. So you leave some of the repetitions out and you classify these repetitions. So you're just using the brain activity. As you can see, or as you saw, you have these arrows for left and right popping up, and these are your ground truths. These are your labels, and whatever the algorithm then says is the predicted label. And you compare that, and that gives you your accuracy.
So why do you use the right hand versus the left leg, or the other way around?
This just makes it a little bit more easy for the subject. So for one, you know that for the foot region, or I hope you know for the foot region, the electrode or on the cortical homunculus for motor area, you have the foot roughly in the middle, so very, very centrally on the cortex, whereas the hands are both laterally. So if you have the right foot, for example, it would be roughly central at the CZ electrode, whereas the left hand would be on the right hemisphere. And this makes it more spatially distinct, which makes the job of the classifier easier, and thus also the job for the subject easier. Also, for example, during walking, you typically have your right foot engaged at the same time as your left hand because of the arm swing and the foot swing.
James wants to know how neuropathy is affecting the stimulation process.
Mm-hmm. It's difficult to say. So neuropathic patients we don't have too often. So I don't want to say one or the other way that it's affecting it. We have had patients, and these patients, it didn't aggravate the neuropathy or anything. So it's definitely not bad for them, but with respect to like benefit or that sort of stuff, it's too early to tell.
Is there a case study for phantom limb pain?
Yeah, Christoph might have more idea. You, Christoph, might have more idea than me. At the top of my head, I'm not aware of anything, but that doesn't mean much. Christoph has a better overview.
We didn't have anybody with phantom limb pain in Heidelberg. Some recoveriX centers were doing it. And there are also studies from Göteborg, for example, in Sweden, where they treat phantom limb pain with motor imagery and virtual reality. So it has definitely a positive effect, but it would be another group study and a lot of work. And Frankie is saying you are doing worse class camera angles. Juni wants to know, is it possible to treat children with special needs with motoric disorders?
Yes, in theory, yeah. One important thing for children, especially when they're treated, is that they have to be compliant. Meaning, because we're recording EEG activity, and as you can see, Evgeny is fairly still while we record that, it makes less sense, for example, if the child is not able to pay very much attention, to really hold still, to really be observant, to really pay attention during the therapy. So, for example, let's put it really plainly, if the child is just running about or wants to move the whole time, the EEG signal that you will get, and thus the therapy benefit that you can give to that child, will just be lower. So what we often tell patients then is, okay, is that child able to really pay attention, that sort of stuff? Because otherwise it might just be worth it to wait a little bit, unfortunately, because we don't want to waste their time, and we don't want to make false promises if just based on the child it's very difficult.
And Gihan wants to know, is there anything that you can do in your free time when you're not training with recoveriX?
Yeah, for example, you can do it either just laying in your bed, for example, or you can also use the recoveriX at home app. So this is basically a mobile app which has the same avatar as you can see for Evgeny. So again, this foot avatar, which again gives you these commands for left and right side, which you can train, for example. So if you want to do recoveriX at home, you can use that as well in an at-home app. Or, of course, perform other therapies or just be active and really build on whatever benefits you get from recoveriX, combining it with other therapies and with just being active in your living, in your daily life.
Very important is that you train your muscles yourself, but this is something that you can just do independently. recoveriX is reducing spasticity, training neuroplasticity in the brain. And then you should do more hiking, more walking, stairs, gardening, whatever you like. So you should activate your limbs again. And then it goes very fast. So we are talking of a couple of days until the muscle strength comes back. You don't need us for that. And finally, people are all walking better. That's especially very visible for gait. So everybody walks faster and better. But you have to train your muscles. Very interesting is also that people report about a lot of pain in session 10 to 15. This is just because they didn't use the muscles for many, many years, so the spasticity goes away and suddenly your muscles hurt. So that's actually a very good sign, and it just takes a few days and then it goes away and people are walking better. Sebastian, Yevgeny, Wosi, thank you very much for the practical session.